Hello everyone. We will speak about the last session of the bladder tumor, which is part 22. We will speak about systemic therapy for metastatic urothelial carcinoma. As you may see, we have treatment paradigms that we will start by first line for metastatic urothelial carcinoma that contain DD MVAC or known as DD-MAFAC, which is actually dose-dense methotrexate, vinblastine, adriamycin, cisplatin. This is the first line, and the other options of the first line is GC, which is gemcitabine and cisplatin. So this is the first line for metastatic urothelial carcinoma. We'll come to if the patient progress after the platinum-based chemotherapy, then the preferred second line treatment is what we call it pembrolizumab. Okay, so the first line for metastatic urothelial carcinoma is cisplatin-based chemotherapy that's using either DD-MVAC, that is dose-dense methotrexate, vinblastine, adriamycin, cisplatin, or GC, that's gemcitabine and cisplatin. If the patient progresses after platinum-based chemotherapy, then the preferred second-line treatment is pembrolizumab. Also, other options of the second line include nivolumab or evolumab and irdafitinib, evolumab and nivolumab. All this is actually considered as a second line. If the patient fails to second line treatment with treated BD1 or BDL pathway inhibitor. So BDL inhibitors. So the third line is then preferred third line treatment option are irdafitinib or infotromab vedotin. So it might be irdafitinib or infotromab vedotin. Systemic chemotherapy for urothelial carcinoma is not curative. Cisplatin is the most effective systemic chemotherapy agent against urothelial combination. Chemotherapy is more effective than single dose or single agents. The first regimens for the metastatic urothelial bladder cancer either, as I mentioned, dose-dense methotrexate, vinblastine, adriamycin, cisplatin, or gemcitabine and cisplatin. The NCCN no longer recommended conventional MVAC, so methotrexate, vinblastine, adriamycin, and the cisplatin is not actually now no longer recommended. So the best one is DDV-MVAC, that does dense methotrexate, vinblastine, adriamycin, cisplatin, or gemcitabine and cisplatin. Okay, the GC, that the gemcitabines and cisplatin, and conventional MVAC achieve a similar survival, but the GS is less toxic. Therefore, this is replaced by DD-FAC. That's mean dose dense methotrexate and vinblastine, adriamycin, cisplatin. Okay, so this is the given on 28 cycles, because the DDA given only on 14 days cycle is more effective and better tolerated. So this is the difference between MVAC and dose dense MVAC. The dose dense, it's usually for 14-day cycle, which is more effective and better tolerated. But the MVAC AAC, that it is given on a 28-day cycle and it is less effective. So it's no longer recommended. The gemcitabine and conventional MVAC achieve similar survival, so it is better, the GC, that is better because it's less effective. GC has high rate of anemia and thrombocytopenia, while the MVAC has high rate of neutropenia, sepsis, mucositis, alopecia, and fatigue. So all this come with MVAC. Okay, so this is why we will use dose dense MVAC compared with conventional MVAC, which is actually for 20 days, 28 days with toxicity higher compared with dose dense methotrexate, vinblastine, cisplatin, adrimycin, and also compared with gemcitabine and cis and cisplatin. Okay. So the side effect, as I mentioned, it's common with this MFAC, conventional MFAC, that have neutropenia, sepsis, and also mucositis, alopecia, and fatigue. Compared with other side effect of GC, which is actually just anemia and thrombocytopenia. This is high rate of this. For patients with M1 disease who are not eligible for cisplatin, carboplatin may be used in place of carboplatin, but the carboplatin-based regimen appears to be less effective. So it is less effective, but if there is no option, we can use it in a patient with M1 disease. Okay, we can replace cisplatin by carboplatin. For M0 patient undergoing radical cystectomy and who are not eligible for cisplatin-based preoperative regimens, a carboplatin-based regimen should not be used. So for patients with M0, it's not advised. It's not advisable, so it is better for M1 if the patient have problem with cisplatin. Cisplatin kill cancer cell by cross-linking DNA. It does limiting toxicity. Those limiting toxicity is nephrotoxicity. Dose limiting toxicity is nephrotoxicity. So the dose limiting toxicity for cisplatin is nephrotoxicity. So nephrotoxicity with cisplatin. Remember, cisplatin N and nephrotoxicity is N2. So that's why cisplatin have a limiting toxicity, which is nephrotoxicity. Okay, so it kills cancer cell by crossing the linking DNA. Other side effects include neurotoxicity as well as nephrotoxicity, hearing loss, diminished cardiac function, nausea, and vomiting. Patients with hearing loss, neuropathy, poor performance status, or renal insufficiency may not be eligible for cisplatin-based chemotherapy. We will come to speak about the target systemic therapy. The target systemic therapy, there are many biochemical pathways that allow cancer to grow. Target therapy inhibit one or more of this specific pathway, which lead to reduced cancer growth. Cancer cells tend to be more dependent on this process than normal cells. Therefore, targeted therapy has the potential to treat the cancer while having less impact on the normal tissue, which might lead to less side effect. In other words, targeted therapy acts upon a specific process by using cancer cell, and that's actually some normal cell. So where chemotherapy acts upon all cells, that's whether they are cancerous or not, but the targeted therapy, it's act upon a specific process by cancer cell, but might be also work on some normal cell. But the chemotherapy that acts upon all cells with no differentiation between cancerous and non-cancerous cells. Example of this targeted pathway include PD-1 or PD-L1 pathway and the FGFR or FGF pathway and nicotine or microtubule pathway. This is a good example of targeted pathway. Okay, so we'll come to speak about the targeted pathway number one, which is BD1 BDL1 pathway. The programmed cell death is known as programmed cell death receptor 1 or programmed death located on lymphocyte 1. When a certain protein binds to the programmed death cell 1, the immune system has reduced the capacity to attack normal tissues, decreasing autoimmune reaction, reduce the capacity to attack malignant tissue by hindering the body ability to kill the cancer cell, kill cancer. BDL1, programmed death cell ligand 1s, is a protein that's bind to the BD1 receptors. Many cancers evade the body defense by expressing a high level of BDL1, which bind to the BD1 and inhibit the immune system ability to kill the cancer. Medication can be blocked by binding of BDL1 to BD1 by attaching to BDL1 inhibitors or by attaching to the BD1 receptors is known as BD1 inhibitors. So however, both BD1 and BDL1 inhibitor achieve their anti-cancer effect by inhibiting the BD1 and BDL1 pathway. There is increased activity, that's the increased immune activity from blocking the BD1, BDL1 pathway can also result in attack on normal tissue, which lead to some of side effects. Since all BD1 inhibitors and BDL1 inhibitors block the same pathway, they all tend to have a similar side effect. Medication that block the BD1, BDL1 pathway are often called immune checkpoints inhibitors because they block an important regulatory component on the immune system. We have another pathway, it is FGFR or FGF pathway, fibroblast growth factor receptors. It's located in many types of cells. When fibroblast growth factor bind to the FGFR receptors, many processes are stimulated, including cell division, that's by mitosis, cell migrations, and endothelial cell proliferation leading to angiogenesis. This is when fibroblast growth factor bind to the fibroblast growth factor receptors. In cancer cell, genetic mutation in the fibroblast growth factor receptor gene can lead to increased activation of FGFR and FGF pathway, which stimulates mitosis, cell migration, and angiogenesis. Stimulate mitosis, which is actually leading to cancer growth. Stimulate also cell migration, leading to the cancer invade into surrounding tissue. Stimulate angiogenesis by leading to the cancer survival and increased capacity for growth. A medicine that blocks the binding of fibroblast growth factors to fibroblast growth factor receptors can inhibit cancer survival, and also cancer invasions. Okay, so it inhibits cancer survival and cancer invasion. Medicines that block the fibroblast growth factor impair growth, survival, angiogenesis to the normal tissue, which lead to some side effect. So this is the medication that's binding to the FGF2 binding of FGF to block binding of FGF to FGFR can inhibit cancer survival and cancer invasion. Also, medication block the FGF pathway can impair growth, survival, and angiogenesis of the normal tissue, which can lead to some of side effects. FGFR is a member of the tyrosine kinase family of molecules. So therefore, medication that inhibits the FGFR or FGF pathway may be referred to as tyrosine kinase inhibitors. Since the FGFR or FGF pathway is also involved in angiogenesis Medications that block this pathway may be referred to angiogenesis inhibitors. We'll come to the third one, which is actually nicotine microtubule pathway for this is it's actually, for example, of targeted therapy, BD1 inhibitors or BDL1 inhibitors. So the nicotine microtubule pathway, this is an example for its nicotine microtubule pathway inhibitors. We have infrutumab vedotin. So the example of the targeted therapy, we mentioned this, BD1 examples, that's pembrolizumab and nivolumab, and BDL1 inhibitor eflumab and azitulomab. This is example of targeted therapy. Okay, but the nicotine microtubule pathway, we have infrutumab vedotin. Also, we have GFR inhibitor like erdafitinib and microtubule disruptors for pathway. We have infrutumab vedotin. We come to speak about pembrolizumab. Mechanism of action of pembrolizumab is BD1 inhibitors. It is an antibody that binds to the BD1 and block the binding of the protein to BD1, which gives the immune system a greater capacity to attack cancer. Intravenous pembrolizumab is FDA approved for the treatment of bladder cancer in the following situations. Patients who have a BCG unresponsive carcinoma in situ, with or without papillary tumors, or who are not eligible for or have elected to undergo cystectomy. So this is an option. Intravenous pembrolizumab is good because it's FDA approved and it is advised for this patient with a BCG unresponsiveness, and also the patient is not eligible for cystectomy or patient or not elected to undergo cystectomy. Also, in locally advanced or metastatic urothelial carcinoma, it's approved for patients who are not eligible for cisplatin-containing chemotherapy and who tumor express BDL1. Also, patients who are not eligible for any platinum-containing chemotherapy, regardless BDL1 status. Also, patients with cancer progression during or after platinum-containing chemotherapy, regardless BDL1 status, including those who progress within 12 months of receiving platinum-based neoadjuvant and adjuvant chemotherapy. We come to infrutumab vedotin. This is FDA approved. We mentioned this is actually this is for the treatment of locally advanced or metastatic urothelial carcinoma in patients who have previously received platinum-containing chemotherapy regimens, and also BD1 and BDL1 pathway inhibitors. This is known as it's actually known as you see in this slide here, is known as nicotine microtubule pathway. This is infrutumab vedotin. Infrutumab, it is nicotine microtubule pathway inhibitors. Okay, pathway inhibitors. Okay, so it is received or advised for patients for treatment of locally advanced or metastatic urothelial carcinoma in patients who have previously received platinum-containing chemotherapy regimens or BD1, BDL1 pathway inhibitors. Side effect includes abnormal blood test, elevated blood glucose, decreased white blood cell, decreased hemoglobin, increased creatinine, decreased phosphate. This is a side effect. Abnormal blood test, elevated glucose, decreased white blood cells, decreased hemoglobin, increased creatinine, decreased phosphate. Common side effect, fatigue, peripheral neuropathy, decreased appetite, nausea, diarrhea, this gaugia, which is alert test, and rash, alopecia, dry eye, dry skin, pruritus. This is a common side effect. But this side effect, abnormal blood test, you can find the patient have increase in random blood sugar and also decrease in white blood cell, decrease in hemoglobin, decrease in phosphate, but increase in creatinine also, because this is diabetes, usually hyperglycemia associated with diabetes, and this is lead to nephropathy, therefore it increases the RFT. Okay, and also the patient might have decreased white blood cell, decreased hemoglobin, and decreased phosphate. All the side effects come with infotromab vedotin, which is actually, as I mentioned, nicotine and microtubule pathway inhibitors. Also, I mentioned fatigue, peripheral neuropathy, decreased appetite, nausea, diarrhea, and dysgeusia, which is alert test, and rash, alopecia, dry eye, and dry skin, and pruritus. Serious side effects, hyperglycemia, ocular disorders, peripheral neuropathy. All this is a serious side effect. Dose of infotromab vedotin is administered intravenously. This is fully processed. If you have also the leaflets associated with this is also beneficial. Monitoring during the therapy monitor should include serum glucose and also RFT. Also consider ophthalmological exam, because we mentioned this patient have dry eye, as you see here, side effect, dry eye, it's okay. This is a common side effect. Also, the blood glucose is high, it will lead to cataract. Okay, so this is monitoring. We need to do a serum blood glucose and ophthalmological. We come to speak about the recurrence. Non-metastatic recurrence in patient when intact bladders. If urine tumor markers is suspected for malignancy, but cystoscopy show no tumors, then perform evaluation as I've done at the beginning of the session of the bladder tumor sessions, muscle invasive recurrence after intravascular therapy, trimodality therapy, or any of the bladder sparing therapy, the preferred treatment is radical cystectomy. Non-muscle invasive recurrence after intravascular chemotherapy in patients with low-grade stage TA tumors that recur frequently despite intravascular chemotherapy, then intravascular may be tried. The effective of BCG is not alert by barrier intravascular chemotherapy. Very important point. Non-muscle invasive recurrence after intravascular BCG for patients who tumor free after induction BCG, then recur during the BCG maintenance with high-risk cancer, radical cystectomy is usually preferred. For patients who are tumor free after completing BCG, then recur within 12 months of their last dose with high-risk cancer, radical cystectomy is preferred management. For patients who are tumor free after completing BCG and then recur more than 12 months after their last dose of the BCG with high-risk cancer, the treatment option include radical cystectomy or repeat the BCG. Induction and maintenance together. Repeat the BCG is likely more favored in those with longer time between the last BCG dose and the recurrence. Non-muscle invasive recurrence after trimodality therapy or after partial cystectomy. This recurrence can be treated similar to de novo non-muscle invasive bladder cancer, I mean with intravascular therapy or with radical cystectomy. Intravascular therapy may favor for low risk recurrence with radical cystectomy and may favor for high risk recurrence. The statistical regard recurrence, 4 factors that increase the risk of recurrence. The size of the tumor. The large size tumor increase the risk of recurrence, especially if more than 3 centimeters, and also the stage of the tumor. If high grade, it's actually or high stage, high stage tumors, this also increase the risk of recurrence. And if the tumor is also the grade of the tumor, if the higher tumor grade or presence of CIS is also increased risk of recurrence. And also multiplicity. Multiple tumors also increase risk of the recurrence, and history. If the patient have history of prior history of bladder tumor, it's also increased. And aneuploidy, this is also the tumor aneuploidy is also increased risk of the recurrence, and lymphovascular invasion and positive tumor marker or positive urine tumor marker after treatment also considered as risk of the recurrence, and also the visibility of the tumors. The bladder tumor visible within 6 months after treatment also considered as factors that increase risk of the recurrence. Bladder recurrence after TURBT. CIS 18% will recur after TURBT, only 30% recur after BCG. TA 50% will recur after TURBT alone, most within 1 year. This is the TA. Low grade TA 50% will recur after TURBT alone, and most within 1 year. T1 more than 70% recur after TURBT alone. Okay, so CIS it's 30% after BCG and 80% recur after TURBT, and TA 50% recur after TURBT alone, and the most within 1 year. T1 more than 70% recur after TURBT alone. After cystectomy, the rate of the pelvic recurrence after cystectomy is less than or equal to 12%. Patients with pelvic recurrence after cystectomy have a very poor prognosis. Recurrence usually occurs within 2 years after cystectomy. After cystectomy without hysterectomy, urethral recurrence occurs in up to 10% of the cases and usually occur within 2 years. This is after cystectomy without hysterectomy, so it's occur in 10% the recurrence occur, urethral recurrence. Here we speak about the urethral recurrence, it's 10% of the cases and usually within 2 years. Upper tract recurrence. Patients with CIS in the bladder are more likely to have upper tract recurrence than those without CIS. Up to 4% of the patients with papillary bladder urethral carcinoma develop upper tract later in life. Up to 20% with the bladder CIS develop upper tract. So 20% develop with the CIS develop upper tract urethral carcinoma, and 4% with papillary bladder urethral carcinoma develop upper tract in later lives. And also history of urethral carcinoma of the bladder. And this is the end of bladder tumor. Thank you.